Department of Medicine Grand Rounds. We have a special guest today in honor of a special man, but before he's introduced, a couple of words. First, William Cumming Rose was born in 1887, but he died on this day at age 98. And you should know that name because he was an American biochemist who researched the role of amino acids in nutrition. And what he did is he took rats and manipulated their diets over and over and over again until he figured out which were the important essential amino acids. And he started by looking at milk proteins and ultimately defined 9 amino acids that he felt were essential. But what's interesting is he convinced students to begin to manipulate their diets so that he can prove that at least 8 of those amino acids were really, truly essential for the adult diet. So that was really important. On this day was the birth of Archibald Vivian Hill. Archibald Vivian Hill was a British physiologist and biophysicist who really worked very hard on understanding how muscle works and how do you develop energy and the production of heat in muscles. And for that, he won the 1922 Nobel Prize for Physiology or Medicine. But today, we celebrate Dr. Theodore Segal. Dr. Theodore Segal, family and friends, established this lectureship in his honor in December of 1982. Many people do not know that Dr. Segal was not an MD, and yet we celebrate him here. He was actually a dentist. He obtained his dental degree at the University of Louisville in 1954. His orthodontic training at Tufts University in 1956. He came back and joined the faculty at the University of Louisville Dental School in 1969. He worked there until the end of his career, where he did tremendous work in helping found the Department of Orthodontics, and he helped train generations of orthodontists. And he was very well known in the community for his efforts to improve education, to improve patient care, and so forth. And because of that, his family and friends came together in '82 and put together this lecture, which we celebrate his honor in the Division of Medical Oncology. And with that, I'm going to introduce Dr. Riley, who's going to present our distinguished guest.
It's my pleasure to introduce Dr. Steve Hum. He did his medical school at Harvard Medical School and then did postgraduate training at the Deaconess and the NIH. I first met Dr. Hum as a fellow at Beth Israel in Boston, and his support, his mentorship, and his friendship have influenced my practice today, so I'm happy to share him with you today. Dr. Hum?
Thank you very much for having me. I have to at least tie it together to say that the Tufts Dental School has a very strong reputation in Boston, particularly their student-run clinic, where they have taken care of the students of Boston for many years. So I'm sure Dr. Segal had a great experience when he was there. But my area of interest is in chemistry, of course. It's breast cancer, something that happened to me by accident because I was originally a Hodgkin's disease doctor when I returned to Beth Israel from the NIH, but it was an all-hands-on-deck situation in breast cancer because of the developments with local therapy and adjuvant therapy, so it changed the direction of my career, and I want to just review some aspects of that over the years. Now, breast cancer, by way of introduction, I think you know is the most common cancer in women. Still, there are over 230,000 new cases of invasive cancer that are diagnosed, projected for this year, and also about 60,000 plus cases of in situ breast cancer, something we'll be dealing with more. This slide is sort of an overview of where we are in breast cancer, and I think what you can see here is that over time, the incidence of new cases has gradually and continues to rise, although it's a little flatter here, and the death rate has declined. I'm very fond of this slide because it really pretty much spans the years that I was involved in breast cancer, starting around 1975 to where we are today. So this sort of is an overview of what my career has looked like in this field. When you look at the five-year relative survival rates, again, we can see that there's been a significant improvement, really about 15% over those 30 years, and even it would be a little bit higher today. Now, Beth would know she'd be scoffing at a 5-year relative survival means very little in breast cancer because there's so many late events, but it is a good measure of the progress that's being made. And I think it's a healthy thing that although things are going well and progress is being made in breast cancer, that's allowed us to sort of take a look at how we got to where we are today and what are the things that are working well for us, where do we need to do more effort, and also we're starting to identify areas that we can do less than we're presently doing today. It's always hard to deconstruct things when you're having some success, but happily that process is ongoing. There's nothing that's more controversial, I think, in the last few years than mammography and breast cancer. So I'll start with some issues around screening. And this really started in 2009 when the U.S. Preventive Services Task Force released their updated recommendations. It was published in the Annals of Internal Medicine, and it really caused a firestorm because they recommended that routine screening, I emphasized in pink, there, or purple, is not indicated in their judgment for women in the 40 to 49 age group. And while they did support screening between ages 50 and 74, they said, you know, you could do this every other year. And for older patients, they said, well, there is benefit, but we don't have very much data, and the older the patients are, the more the issue of overdiagnosis starts to creep into the equation. They didn't have any new data on which to analyze this. They looked at the same 8 international trials that have been used in all the studies of mammography, but they took a different slant. For one thing, they looked at the number needed to invite to prevent one breast cancer death. And this is the number of women you'd have to invite for 10 years of screening to prevent one death. So here's the basically 40 to 50 age group. Here's the 50 to 59, and so on and so forth. So it really is this sort of number that led them to simply not recommend routine screening in the 40 to 49 age group. They didn't say it should never be done. They just said it should not be just a matter of population-based, age-related practice because of this. Basically, this reflects, because you can see the relative risk for breast cancer mortality in screening is really pretty similar here, but what it represents is the fact, or what it reflects is the fact that breast cancer is not as common a disease in younger women, so the returns are just statistically lower. If you looked at life years saved as opposed to mortality rates, screening in younger women would look like a much more favorable process because young women have a lot of years that they should be living. But based on mortality rate data, they felt that you could not make a case for routine screening. The data for the older women with the every other year screening, just to summarize it for you, represented the fact that if you did screening every other year as opposed to yearly in the 50 to 69 age group, you would have about 2 excess breast cancer deaths per 1,000 women screened. So there'd be about a 0.2% of a 1% difference by going to every other year screening, and that would cut down the number of adverse effects of screening by 1/2. You know, less expense, less anxiety, less false positive, less biopsies, etc. So their feeling was every other year would likely work fine. But of course, this is a matter of public health policy. They weren't trying to set that for us. Blyer then followed up this with a very controversial article. Again, everything on mammography is controversial because you get a lot of pushback from the radiologists. But he looked at 30 years of mammography. This was a New England Journal publication, and he showed that basically this is the uptake of mammography. So we were doing a good job getting people to have mammograms, and with that you see early stage breast cancer went up tremendously, went up from about 112 cases per 100,000 women to 234, so almost a doubling. Early is being defined as DCIS or stage 1 breast cancer. But what was striking is late stage breast cancer was really pretty steady. All we could demonstrate for all this increase in diagnoses was about an 8% reduction in late stage cases. So if you thought that every early case you found was avoiding one late case, that clearly was not the case, because it turns out that there's an excess of about 100,000 cases per, about 100 cases for every 100,000 screened that are excess diagnoses. That is, those that would not be projected to progress to advanced breast cancer. And this was also controlled, I think, pretty well by looking at the younger patients under age 40 who did not have routine mammography, of course. And you can see during the same time interval, the early stage and late stage diagnoses were quite flat. So this clearly represents finding more early stage disease as a result of mammography, but only a small proportion, maybe 8% of those, are cases that would have gone on, we think, to advanced breast cancer. So that's something for all of us to chew on. And then this past year, the Canadian national trial was reanalyzed and represented in the British Medical Journal. This is a very good trial. It's one of the 8 that everybody cites, but it's good because it has 90,000 women in the trial. It's a relatively contemporary trial. It involved 5 years of screening or a physical exam without mammography. It started in 1980, so it's thought to span the era of contemporary breast cancer therapy. And the key findings of the Canadian trial as presented this year was that there was no mortality benefit, none, by adding mammography to physical exam in any of the patients aged 40 to 59. And overall, again, with this theme of overdiagnosis, they calculated by their modeling that about 20% of the cases that were found by mammography were what we call excess diagnosis. The overall data is reflected, I think, in this curve. This is the overall mortality up to 25 years in this trial, and I think no matter where you're sitting in the room, you can see that those curves overlap. The slide that's better, I omitted from the slide accidentally, but it actually focuses on the cases of breast cancer that were diagnosed during the 5 years of the screening trial. In other words, if you had a diagnosis by mammography or in the control group, what happened to those roughly 500 patients in each arm, and the mortality over 25 years for those patients diagnosed in that window, again, is the same. It was 171 deaths in the control group and 180 deaths over 25 years in the mammography group. So this is a trial that had enough numbers, that had enough quality, that was randomized, and although you can argue about all sorts of fine points, these trials are very simple, so they're very complicated, ironically, to analyze because of the simplicity of the design, but I think it again fit with what I've been showing you about the Preventive Services Task Force, about the Wire article. We're sort of calling into question how much we're really getting in terms of mortality reduction. So what we're doing today, of course, is population-based screening. People are sent for screening based on their age and no other real criteria. So it's a uniform criteria for being screened, just your age. There are all sorts of new technologies out there. Our mammographers have new machines every year that they're pushing, whether it's digital or CT, tomosynthesis, whatever, but there's very little outcome data for any of that. And as I said, the recent analyses have suggested that there may be a lower impact on breast cancer mortality and some real concern about overdiagnosis. Now, this is not bomb-proof data. This doesn't mean go out and stop getting mammograms and don't encourage any patient to have it. And I think it's fair to say there's some healthy discussion going on about what we're really getting from this and how we can make this better. Now, primary prevention, of course, is avoiding breast cancer, not finding it when it's quote, early by screening. And we have quite an experience over these years with chemoprevention. It starts with tamoxifen. This observation arose initially from adjuvant therapy data, where we looked at patients who had a breast cancer, received tamoxifen as adjuvant therapy, and we looked at their contralateral breasts over time. And in this one NSABP P trial, for example, you can see that, let me get back to that, sorry. You can see that the number of invasive breast cancers in the contralateral breast was reduced by half of the patients who were getting tamoxifen. So that led to prevention trials to say, well, if it seems to have a contralateral protective effect, why not give it to high-risk patients before they get a breast cancer, see if we can avoid breast cancer. And that was the P-1 trial, which was run in the United States in the 1990s. This trial definitely showed benefit. It was 5 years of tamoxifen versus control. 13,300 patients randomized. And what you can see looking at the 50-plus age group is you have, again, invasive and invasive breast cancer. Again, the risk cut by 1/2. It also was somewhat protective against fractures because tamoxifen is a SERM, so it's got a weak estrogenic effect on bone. It did come with risks of endometrial cancer and blood clotting, but again, these are relatively small. These are the absolute number of events, and remember they were randomized to 13,000 women. But when you look at the younger age group in particular, you can see the benefit is similar. Again, you cut the invasive breast cancers essentially by 1/2, but in the younger patients under age 50, when they start tamoxifen, there was no increase in uterine cancer or in vascular events. So that's a very good group in terms of therapeutic ratio. The P-1 trial has always bothered me, however, because the trial met a predefined stopping rule. It was unblinded after only 3.5 years. When it was unblinded, I think only 57% of the patients had been followed for more than 4 years. So it was an awfully early trial. And it raises the question, is this really a prevention effect that you're seeing? If the curves are separating, this is invasive breast cancer, you can see they're really separating in the first year or 2 years of the trial. Now, breast cancer we think of as a disease of months or years, not days or weeks. And if you were preventing it, you would not expect to see a major effect right out of the starting blocks. I mean, you'd think there'd be a lag before the effect of preventing cancer would show up. So that suggested to many of us that what you were seeing was probably a therapeutic effect on preclinical or pre-diagnosed cancers. It was just too early. And the trial was, of course, contaminated by being unblinded and allowing patients to cross over at that point. But we were kind of saved by the Brits who did the IBIS 1 study. This is almost the same design as the P-1 trial, where patients were randomized to tamoxifen or placebo, pretty much the same criteria, and again, 5 years of treatment. What was different about IBIS 1 is that the British felt that they didn't want to unblind the trial, so they kept going. So we were able, even at 5 years, to observe for another 5 years patients who had had tamoxifen or had placebo and had not crossed over. And what you can see on this slide from IBIS 1 is this is the one line would be if there was no effect. So this shows about a 40% reduction. This is all breast cancer, invasive breast cancer, and ER-positive invasive breast cancer. But you can see, other than this one anomalous year where it spiked up, that the curves continuously remain below 1 and are actually falling more overall in years 5 through 10 than they were in the first 5 years, which really, I think, starts to suggest that you're in a prevention effect. If you see it on the forest plot, you can see that this is the effect of tamoxifen versus placebo in the 5 years of therapy, and this is the effect in the next 5 years. So the IBIS 1 gave us at least confidence over a 10-year period that there may well be a prevention effect, and that in the second 5 years, that 5 years off therapy, you're in a wonderful therapeutic ratio again because its tamoxifen risks are gone, and the benefit is clearly persisting or even increasing in terms of what we see clinically. Now, aromatase inhibitors are sort of have eclipsed tamoxifen just barely in the postmenopausal setting. These are drugs that don't block the estrogen receptor like tamoxifen, but they block the conversion of adrenal androgen into estrogen. Remember, a postmenopausal woman is not getting ovarian estrogen, but they have a lot of androgen around, and breast cancers overexpress aromatase to convert that androgen substrate into estrogen. So aromatase inhibitors are very good in women that have postmenopausal physiology, and we did the same analysis initially that showed us in the adjuvant trials if you looked at the contralateral breast. Again, there was about a 50% reduction in that contralateral breast in seeing new breast cancers on that side. And in these trials, the control group was tamoxifen. So this is like 50% better than the risk reduction that was achieved in the control patients who were getting tamoxifen in these trials. So it's a 50% reduction of the residual risk that would be achieved with tamoxifen therapy. So that looked very good. And there have been a couple of AI trials now published. Again, the first one was MAP3, which I'm not going to show because it had exactly the same problems as the P-1 trial. It was unblinded in about 3 years. I don't know why the New England Journal published it, because I would have the same objections to the interpretation of the data, but the Brits again have IBIS-2, which is the same as IBIS-1 type of design, but that trial is being maintained unblinded and has now been reported for its preliminary report that shows us that with a median follow-up at least of 5 years, not 3 years, there is a hazard ratio of 0.47, about a 50% reduction in cancers, and the projected 7-year cumulative incidence is again about 50% reduction in cases. So the longer follow-up of IBIS-2 will confirm that AIs are also a good strategy for chemoprevention. I think that will be ultimately verified. So the Preventive Services Task Force suggests, and I quite agree, that we're placing too much emphasis on population-based screening and too little emphasis on chemoprevention. That for chemoprevention, we should be focusing on women, particularly on the younger side of the age group, who we can identify having a 5-year breast cancer risk of the order of 3% for 5 years. And I just gave you this for reference. A 40-year-old woman should have a breast cancer 5-year risk of about 0.6%. A 60-year-old woman has a 5-year risk of about 1.3%. So we're looking at 3 to 5 times increase in breast cancer incidence. And those are women who we think should be seeing more chemoprevention than they do. And I think we have data that suggests that they could benefit from doing that. Now, the issues in both screening and prevention, if you can follow my drift so far, really converge on this idea that we have to have an accurate risk assessment, because it doesn't really make sense to do things just based on patient's age. I mean, age is really not an indicator of anything in breast cancer. We know that incidence goes up with increasing age as the cases accumulate, but I mean, age is a lousy criteria to use for strategy. So we need a good risk assessment tool, and we don't have one. We use the Gale model today, and this was designed for population-based screening, not individuals. The Gale model, maybe I'll get good at this by the end of the talk. The Gale model has these criteria in it. It's heavily driven by the number of first-degree relatives with breast cancer and the number of biopsies that have atypia. But the Gale model leaves a lot out. The Gale model doesn't cover for breast density, which by itself is a single factor can be associated with a 4 to 5-fold risk of breast cancer at the highest level. It doesn't have non-first degree relatives. That's the whole father's side of the pedigree. It doesn't, it's not suitable for those with a BRCA mutation in the family, and it doesn't cover other lifestyle or exposures such as alcohol consumption. This is a dangerous message, I guess, in an urban city, but 3 alcoholic beverages a day increase your breast cancer risk by 30%. Obesity, hormone replacement therapy, prior mantle radiation for Hodgkin's, none of these things are accounted for in something like a Gill model. And in fact, when you look at something called the concordance statistic, which is the discriminatory accuracy of the Gill model when applied to individual cases, the concordance statistic comes out to be 0.58. And again, for comparison, the coin toss is 0.50. So it's not a terrific risk prediction model at this point for us. So I think the number one priority, I think, to get screening and prevention right is to develop a reliable risk assessment tool, because if you have that, you can then begin to identify populations that need more rather than less screening, and certainly more reliably patients who are going to be offered chemoprevention. And I don't take chemoprevention lightly. It's a big deal to ask a woman to take medicine for 5 years or longer that does have some side effects and some risk to prevent a disease that they don't yet have. So we want to be able to fine-tune this absolutely as much as we can. So I want to move on in the second portion of this to the things we've experienced in treatment, having dealt a little bit with screening and with chemoprevention. These are areas that we think we're over-treating patients. And again, in my mind, in a perverse way of looking at it, I see this as great progress, that we're looking at what we're doing and trying to deconstruct some of it and tear it down a little bit. Ductal carcinoma in situ, reducing the extent of surgery for invasive breast cancer, eliminating radiation, hypofractionated radiation. I'm happy to see there's some nice investigation going on here in that regard. And also avoiding chemotherapy in many patients with ER-positive breast cancer. So there's much going on in the area of treatment that's evolving. This is ductal carcinoma in situ. This is seen on a mammogram, of course, and you get these pleomorphic linear branching microcalcifications. It almost never today is seen as a mass. This is a common finding only on a screening mammogram. These patients get biopsied and they have a result that says they have ductal carcinoma in situ. That's a true pre-invasive malignancy. It's confined to the walls and lumens of the duct. But we know that ductal carcinoma in situ has the capacity to progress to invasive cancer in that area of the duct system, at least in some of the patients. Again, there is a very nice British trial done by Jack Cusick and colleagues that was originally presented back in 2009 in San Antonio. And what they did is they looked at the effect of excision, of radiation therapy, of tamoxifen in ER-positive DCIS. The standard of care for DCIS had always been a mastectomy. Then as we got to breast-conserving therapies for invasive cancer, everybody started saying, including the patients, wait a minute, if I just have a situ cancer, why do I have to have a mastectomy when my neighbor who has an invasive breast cancer with positive nodes can have breast-conserving therapy? So we quickly caught up for that, and we did trials with excision and radiation, and showed in several large trials that looked very comparable to doing a mastectomy, and many patients with DCIS today can be treated with excision and radiation. But Cusick and his team went a step further, and what they wanted to do is they wanted to look at the value of each of these things. So they randomized patients in a 2x2 format. That the control group represents DCIS that was excised with 3 margins. Then they randomized to tamoxifen or not, and to radiation therapy or not. So some of the patients got surgery alone, some got surgery plus tamoxifen. Everybody got surgery. Some patients got radiation plus surgery. Some patients got both tamoxifen and radiation. And while there's no question that radiation, for example, adds a lot in reducing breast cancer events, 14% in absolute terms, what is interesting to me is in this trial, the follow-up was almost 13 years. Of the DCIS cases that had only surgery, no tamoxifen, no radiation, the rate of breast cancer events was only 22%. So that meant more than 3/4 of the patients, nothing happened to them in 13 years when you just excised the DCIS. So I think that was a pretty interesting observation. It validated the proportional benefit of adding the other therapies. No question that 22% versus 6%, a lot of improvement with tamoxifen and radiation, but what struck me was how few events there were over 13 years in the group that had only surgery. So the effort has been on to do something about DCIS because it's the fastest growing diagnostic group as a direct effect of all this population-based screening. We're finding these microcalcifications. Once you see them, you don't biopsy it at your peril. So they get a biopsy, they have DCIS, and it's what to do with these patients. It's an unmet need, basically. What we need is to try to figure out, if we can, are some cases of DCIS identifiable as favorable and would do very well with very minimal therapy, maybe a biopsy only or an excision only, and other cases it would be destined for trouble if you don't really throw the book at them and give them radiation plus or minus tamoxifen. So Genomic Health, among others, has tried to develop genomic assays using gene expression profiling of the tumors to come up with something that would separate good from bad DCIS, if you will. Their first effort, which could be called sort of version 1, was also published in the Journal of the National Cancer Institute, I think was not a success. And I think this is not ready for prime time because what you can see here is that their low-risk population still had a fairly significant recurrence rate in excess of 10% by 10 years. So they didn't really identify successfully a very low-risk group, and most of the patients in their initial assay fell into the low-risk type of score. So I think the discriminatory value of this is not good enough yet. This has to be fine-tuned. The genes that they suggested had to do with what 10-year tissue was available from the NSABP and to wrap their gene set around the characteristics of the study population they wanted to look at. I think they made some compromises that maybe lower the precision of the assay. But I think although they're pushing this for commercial use, I don't think it's very good, and I wouldn't recommend it, but it serves to illustrate that this is a really important problem to try to be able to back down the therapy of these patients, probably lots of them. A second area that's important is this issue of margins. Well, this isn't surgical grand rounds, I realize that, but if you look at breast cancer surgery today, most patients that we see are having a lumpectomy and then radiation therapy. Probably 80 to 90% of patients are eligible for this type of therapy, and it's commonly practiced. We've always felt that the patients need to have clean margins around the tumor to then be adequately excised to have radiation therapy, but nobody's really known what those margins should be. And what's striking is that about 30% of patients who have a lumpectomy end up going back for a re-excision. And over half of those that are being re-excised are being re-excised to simply widen margins that are negative, but somebody on the multidisciplinary team decides that it's too close for comfort. I mean, literally, there's been no consensus about what an adequate margin is. So a meta-analysis was done by a consensus panel. Monica Goro wrote this up in the sounding board with one of our pathologists in the New England Journal in 2012. When they looked at the prospective trials on local recurrence and margin, they couldn't find any statistical difference between margin widths that were 1, 2, or 5 millimeters. And we know that an involved margin is not good, but it wasn't clear that there was any advantage to excising anybody to make a negative margin a bigger negative margin. And the current recommendation, which has now been endorsed jointly by medical oncology, by surgery and radiation therapy, is simply if you have no ink on tumor cells, you have an adequate margin. So this is right off the bat going to cut down on probably 10 to 15% of the re-excisions that patients are undergoing. So I think we're being a little more relaxed about margins. There's another surgical trial I won't go into called Z11 that also looked at the need not to remove additional axillary nodes if 1 or 2 sentinel nodes are positive in patients receiving radiation. That is only a single trial. It has its detractors, but it also looks there that less axillary surgery can be done in many cases. So I think some definite changes to reduce the amount of breast surgery are now being put in place, and I think that's effective. Now, obviously, we spent 30 years justifying breast-conserving therapy. This is a 2002 paper from Bernie Fisher in the New England Journal looking at B06. This was the 20-year follow-up, and it is comparing patients that had a total mastectomy, a lumpectomy, or a lumpectomy with radiation. And while the lumpectomy is a little bit worse, you can see that there's no difference between mastectomy or lumpectomy and radiation. And this isn't a single study. In fact, there's a ton of studies that have looked at this. If you look at the years of follow-up, they're all quite lengthy. There are a lot of patients in these. This is the analysis and overview. Literally showed the overall survival. None of these have a statistically significant difference. So we feel very confident that lumpectomy meeting the standards of a free margin and radiation therapy is equivalent, at least to a mastectomy for patients that can meet the surgical criteria for having it. What's new is we're now re-examining, do we really have to give the radiation at all? And this started with the paper by Kevin Hughes that's been published in Times, most recently in 2013. And what Hughes and his colleagues in CALB did is they took elderly women who were 70 years of age or older with node-negative, ER-positive breast cancer. And they said, well, what if we excise them, and give them just tamoxifen as opposed to radiation therapy after excision and tamoxifen, which would be standard of care. And not surprisingly, you can see if you give versus omit the radiation, there is a higher local recurrence rate, about 7% in absolute terms, statistically significant. But if you look at the ultimate mastectomy rate, distant metastases, death, no difference. And what's really striking on this slide is in this 70-plus cohort, almost nobody died of breast cancer in either group. So you've got so much competing risk when you're 70 years of age that you can get away with a little less because the patients are not going to die of this disease no matter what you're doing. And this year at San Antonio, the PRIME-2 trial that was presented, and that now has pushed the age range down to 65, almost identical study to the Hughes study, smaller ER-positive cancers, negative nodes, adjuvant endocrine therapy. They excluded high-grade or lymphovascular invasion. The follow-ups are still short, but again, it looks very, very good. Distant recurrence, which would be a surrogate for ultimate breast cancer death, of course, very low in both arms. I think PRIME-2 is early yet, but it looks like the observations from the Hughes study, which has more than 10 years follow-up, are likely to be extended down into the 65 and up patients. So as you get older, again, this issue of over-treatment, just as over-diagnosis and screening in the elderly patients starts to be a real issue. These people are simply not dying of breast cancer. The other therapies that we are using are good enough that it just sort of takes that off the table so we can do less. Now, radiation therapy, where it's given, we learned that it can be given faster. This is not a problem in Boston or in Los Angeles because in Boston, there are as many radiation centers as there are Starbucks. You could literally take the directions by saying, like, turn left to the third radiation center. But in much of the country, patients drive for hours to get to radiation. And if you can, that literally has led to, we think, too many mastectomies in parts of the country where there isn't good access to radiation. That's not good, where people would qualify for breast conserving therapy. But also, it just affects a lot of hardship of having to get these people. I remember I was a guest out in Iowa and talk out there. They have patients who literally drive 300 miles every day to get breast radiation. So being able to shorten radiation, as Whalen and his colleagues did, they were able to shorten it by hypofractionating the dosing. So they're able to get radiation done in basically 22 sessions as opposed to, or 16 sessions over 22 days as opposed to 5 weeks plus for 25 sessions. So this is significant if you're a patient that has to drive, an hour and a half each way to get radiation every day. So I think this looks great. And last night at dinner we were talking about a program going on here for ECIS for patients being radiated, where they're being radiated on a once-a-week basis. And if that works out as is hoped, that could be huge. Also, it will represent, I think, doing less therapy and showing that we can have a good result and do something that makes sense in doing that. Now, the big area for me, because we're medical oncologists, is this notion of giving less adjuvant chemotherapy. 2/3 of all breast cancers are hormone receptor positive. The estrogen receptor is sort of the ultimate and first targeted biologic therapy, since it was first shown that estrogens were effective by Bateson in 1896, so in literally more than a century of anti-estrogen therapy in breast cancers. But the question has always been, if you're ER positive, which is 65 or 70% of that population, they're going to get anti-estrogens in all likelihood. The issue is, do they also need chemotherapy? When you look at SEER data in the United States, you see that these are women who had a greater than 1 centimeter but small ER-positive cancer with negative lymph nodes. And you could see that in the early 2000s, we're still treating younger women, almost 3/4 of them with adjuvant chemotherapy, and even for women in the 50 to 70 age group, fully 1/3 of them were getting adjuvant chemotherapy. So it was felt that this needed to be re-examined. We knew that our colleagues in Europe, particularly in Great Britain, gave a lot less chemotherapy for ER-positive breast cancer and had very comparable results. So it was considered a target to see if we couldn't reduce the chemotherapy needs of patients by at least 1/3 or so. And to do that, a variety of genomic assays, building on technology that became available with the Human Genome Project, have been applied to tumor specimens to try to figure out what gene expression profiling might predict for chemotherapy need or lack of need. There are many assays that are out there. The Genomic Health assay is the one that's had the most traction in the United States, but it won't either be the last or the best before this field is fully advanced, but it basically uses 16 genes and 5 reference genes. You can use a paraffin-embedded tumor specimen, and what you get out of it is something called a recurrence score. So if an individual patient has a recurrence score of 25, that would show that their 10-year risk of distant recurrence would be about 17%, something like that. And that's assuming 5 years of an anti-estrogen. So most of us in our field would say, gee, if they still have a 17% risk of distant recurrence despite 5 years of tamoxifen, that's high enough to justify some chemotherapy. On the other hand, if their recurrence score is 10, their distant recurrence risk is 5%, so that even if chemotherapy could, as it usually would be assigned, a 40% reduction in risk, that would get you about 2%. And many patients would say, I don't want chemotherapy for a 2% additional likelihood that it would benefit me. So this stuff has been widely used. As I said, there are other assays that are just as good. The PAM50-ROR is probably actually biologically a better assay than the archetype recurrence score, but this approach is being taken, and we have found with recurrence score that the higher scores not only predict a higher risk of recurrence after endocrine therapy, but a lower benefit in general from endocrine therapy, whereas these low-risk recurrence scores not only do very well with anti-estrogens, but when we examine these patients that receive chemotherapy, we see little additional chemotherapy benefit. So it might be identifying a genotype of tumor that not only doesn't need chemotherapy, but doesn't seem to benefit very much if they're given it. That is, they're just not very chemotherapy sensitive. Most of these assays are driven by proliferation genes, and not surprisingly, tumors with low proliferation might be less susceptible to treatments that are primarily targeted against cycling cells. So all of this makes sense and has become pretty standard care at this point, I think. Now, this is the TAILOR-X trial, which is looking at recurrence scores and randomizing patients in this middle range of 11 to 25 to see formally whether hormone therapy alone is as good as the two together. This trial is fully accrued. We have 6,000 patients on it. It probably is going to report in the next year or so. It's an event-driven analysis, so we have to wait. But that will add some clarity as to what to do with this middle ground, and maybe we're going to be able to bifurcate the middle zone or something into those that do or don't need therapy. But this type of study will be very important, and there's a trial going in Europe with an assay called Mammoprint that's doing much the same thing as the MONOGRAPH trial. So we're focusing in on this middle group of patients, which are presently sort of ambiguous. Now, for all the things that I've mentioned to you that require less therapy, there are some areas where more therapy is probably useful, and one of those is in the endocrine aspects of breast cancer. We know that estrogen receptor breast cancer does things late. You know, the lay public view of cancer is if you're well in 5 years, you have a survivor party and get on with your life. But in breast cancer, that's not really the case with ER-positive breast cancer. As you can see here, for recurrences and for deaths, the major events occur beyond 5 years. We always show an argument that we should send these people to their primary care physicians in the first 5 years and tell them to return to begin follow-up at year 6, because statistically more of the events are going to be late events. Now, late events don't necessarily mean that you need to give prolonged therapy. It might be that all the benefits you get early on, even if the events are late. But we also know that there's a carryover benefit from 5 years of tamoxifen. For example, I showed you that in the prevention trial, if you remember the slide on IBIS 1. And when you look at the overview analysis for invasive breast cancer, you can see that these are the hazard ratios for tamoxifen versus no tamoxifen. Here's the first 4 years. Here's it isn't until 10 years that the hazard ratio is basically 1.0. It never gets worse. The curves never come back together, but they separate continuously for the first 10 years. So 5 years of tamoxifen has a carryover for at least 5 years of therapy. So you're getting a prolonged effect, at least out to a decade. It took 2 large studies that are the Atlas and Adam trials that looked at 10 versus 5 years of tamoxifen and randomized about 20,000, 17,000 patients in that endeavor. And as you can see, in years 5 through 9, there was no difference between the group getting that second 5 years of tamoxifen and the group that stopped at 5 years, because there was a carryover effect from the 5-year group. But when you got to 10 years and beyond that, you could see that there was a reduction in hazard ratio in both trials. They were made to be analyzed together for giving longer therapy versus stopping at 5 years. And for this is the data for all years on the trial. So it took a very long trial with a lot of follow-up to see this. But when you focus on the results beyond 10 years, you can see that longer therapy is in fact a bit better. And in terms of overall survival, we also see that. This is the overall survival for the whole trials, and this is beyond 10 years, a 16% improvement in overall survival. And that's really important because overall survival tells you that the more patients are truly alive. You could have a benefit where the breast cancer mortality is lower, the people are dying of strokes or uterine cancer in a way that zeroes out the gains in terms of breast cancer therapy. But in this improvement in overall survival, it says that you don't harm people by taking 10 years of tamoxifen. Indeed, if they take 10 years, they're much more likely to be alive for any reason than if they don't. And we know that tamoxifen has some favorable cardiac effects also, that it reduces cardiac events with the adjuvant trial. So longer therapy with tamoxifen is starting to become of great interest. We're also looking at longer therapy with aromatase inhibitors. We have already successful trials with tamoxifen for 5 years and then aromatase inhibitors for 5 years after, but we're now looking at the results of 10 years of an AI after 0 to 5 years of tamoxifen before it, and that's going to be reported out in this next year. So I think it's not unlikely that we'll see positive data for prolonged therapy with AIs also. It's not as easy as it seems because patients don't take therapy just because you prescribe it. Until a few years ago, we always felt like, gee, we're like Harvard professors. If we tell somebody to take this pill, of course they're going to take it. Well, it turns out when you start looking into it, that they don't take it. My colleague Ann Partridge did this study in an adjuvant trial that we did at Dana-Farber. It showed that by 4 years of therapy, only 50% of people were taking tamoxifen as was prescribed. That doesn't mean they weren't taking any of it, but they weren't taking it as prescribed. I had patients who say, well, Dr. Crum wants me to take this every day, but I know in my heart I only need to take it once a week. I mean, people were doing all sorts of things. So, getting patients to adhere to a medical regimen for 10 years is going to be a real challenge, and we need to definitely work on our numbers needed to treat type of analysis. This is from the MA17 trial, which had 5 years of treatment, followed by either letrozole or placebo for another 5 years. And what you can see is the node-negative patients, the absolute differences in the trial were consistent across all groups, but if you broke it up by node, or the relative benefits were consistent across all groups, but the node-negative patients had an absolute benefit that was only 1/3 that of node-positive patients, so the number needed to treat was 13 if you were positive for that one occurrence, but that was if you were node-negative. So I think we need to focus on the population that needs therapy. 2 other things quickly, and then we'll stop. Follow-up after primary therapy. Most recurrences are found by patients, not by doctors and not by tests. And I think we know now that routine films, body imaging, tumor markers is simply not indicated in our patients. Mammography, yes, because you can find curable local recurrences or curable new cancers, but body imaging and markers, I think, are not useful. And this is one slide from the JAMA article. It's a dated article now, but I think it's a great one. I have it only in my exam room because every patient comes in and says, well, doctor, shouldn't I have a CT scan or a bone scan? Don't we need to stay on top of this? Because the intuition is in the population that early detection of any cancer event is good. But this is 12 years of follow-up, of clinical follow-up versus intensive radiographic follow-up plus clinical, and you can see up to 12 years, there's no difference in outcomes. So the reality is, yes, you can find things, but it doesn't improve outcomes for patients. Early detection of metastatic disease is not helpful. Now, and then finally, patients are always asking us, doctor, what can I do? I think the hardest thing of the cancer diagnosis often is the feeling of helplessness that I have this thing in my body and there's really not much I can do. The doctor's giving me pills, but what do I do? And it's been hard to show advantage for lifestyle mods in breast cancer, but we have some that are important. So we know that even small amounts of weight loss restricting, not eating too many hot browns, I think would be good. Taking your alcohol prescription, so we've eliminated your signature dish, your signature drink. Say, get some exercise, better than being sedentary. You don't have to be a triathlete, but you can't sit on the sofa all day watching television. And there's some data not bound to that aspirin can be helpful as well. So I think in summary, what we should think about doing at present is, probably less mammography. Again, I think right now we're in a controversy. I think there are a lot of arguments still to be resolved. We don't have to go change the practice today, but keep an eye on it. I think we definitely need less treatment for DCIS, and we need to develop ways to sort their cases out. Less surgery, as we've talked about. Probably less radiation therapy for patients above 65. Shorter courses of radiation with hypofractionation where we're going to give it. Certainly less radical chemotherapy and less to be able to survivors. I think we need more chemoprevention. We probably need longer endocrine therapy in many of the positive cases. And we need to spend more time, I think, counseling patients on lifestyle modifications and a survival program. We also need clearly a better assessment tool for individual risk, and we need to have systems that are good at identifying patients who need genetic counseling and genetic testing, because the bar for this is very low. So because we're in horse country, I thought I had to get in one slide that was relevant to all of you. I didn't need this final quote, and I'm happy to answer it.
I like the equine medicine. I'm going to have to steal that slide from you. Thank you so much. This was very informative. Before I ask the audience for questions, I wanted to get you back to a recommendation for screening. And the reason is very selfish. I have a wife and 2 daughters. And tonight, I'm going to sit down for dinner. My wife is going to say, what was my rounds about? And I'm going to say it was about breast cancer. She's going to say, what did they say about screening? So what is the recommendation for my wife and my daughters about screening? Women who don't have any excess risk for breast cancer other than the fact that they're women.
Well, I think if you're 50 and over, the data looks pretty favorable, particularly in the 60 and 70 group and the number needed to invite. So I think I'm fine with screening at 50 for now. And I think for a woman who wants to do it every other year, who really doesn't have any high-risk features, the data looks pretty good for doing that. So I think that's acceptable. But, there are a lot of differences of opinion among women. When I shared this data with my wife, she said, good, I'm not going every year. And then other people would say, oh no, they're taking my mammograms away. All these old white men are going to stop me from getting mammograms. The activist movement has worked for 30 years to get these studies for patients, and they're afraid that their progress is going to be rolled back. I think they don't understand what the level of progress has been. But 50 and up, I'd say I would keep going possibly every other year. 40 to 50, I would say it would depend on family history or other risk factors. If you obviously have a family history with a striking pedigree, those patients would be well suited to do mammography. And for your daughters who are probably younger, I don't like mammography at a young age. Radiation therapy is carcinogenic to a young age breast. So even when there's a family history, we'll use whole breast ultrasound or MRI until patients get certainly above 35. I think mammography has a little role in a 25.
Okay. Thank you. Questions? Chris?
Yeah. What about soy? With soy and everything, and it has estrogenic effects, and should people...
Only with alcohol. No.
Yeah. Well, I think soy is a complete mystery to me. I try to follow these things, but you can literally identify data that says that soy is harmful, that other data that soy is helpful, and other data that says soy is harmful or helpful depending on what age you are when you're ingesting it. Remember, breast cancer is fascinating because many of the events that determine what's going to happen to you probably occur between puberty and adolescence. So it makes it really hard to understand when you're dealing with 50, 60-year-olds what might have been issued that led to them being in your office? I think we really don't know. So I always tell patients, common sense. If you like soy, there's nothing wrong with an occasional stir fry. I wouldn't eat it 20 times a day. If you're taking so much soy that your hot flashes have all gone away, I guess I'd be very concerned about that. But most people don't report that to me. So I think it's fine in moderation. And you can drink also in moderation. You can have your 2 glasses of excellent bourbon on the weekend. We just don't want you to have 2 every single night. But and all lifestyle things, that'll be like one factor. It's not like the wheels will fall off the wagon if you're perfect in every way and you have too much soy. I mean, these things like that is harmful.
Question? No other question? I'll give you the last question, then I'll invite Beth up here. What's new? Give me just a glimpse out of the new discovery about the pathogenesis of breast cancer, because clearly this is just chipping away at bits and pieces of what we know. But the next leap will come out of some big discovery. Where are we headed?
Well, I think we know why about 10% of people get breast cancer, because they have mutations in tumor suppressor genes, BRCA1 and 2, or in that pathway. It may be that it's actually much higher, that there are other genes in the pathway or epigenetic silencing that contributes to that, but it still leaves the majority of cases not understood. And I think, as I alluded to, I think part of the problem in understanding it is that the die may be cast for many people in adolescence right after puberty, and I think it's just so hard to identify what's going on. So I don't actually see that we're going to find a unifying cause of breast cancer anytime soon. We'll find more genes, more pathways, more genetic mechanisms, but it will still leave a lot of cases where the only risk factor is that it's a woman and that they're Asian. It is Valerie Burrell, who's the epidemiologist at the University of Oxford, has done some really interesting work in Asia, looking at rural versus urban Asian populations. And in the rural women, they don't have a high incidence of breast cancer because they're pregnant often continuously from their teenage years to their 30s. When they're not pregnant, they're nursing. The urban women now they have 2 children, they have it late, they have careers, they have MBAs, they have law degrees, whatever. So we think that age at first birth is protected. The breast wants to be a milk-producing gland, and the more it does that at an early age, it seems to have a stabilizing effect, and it seems to upregulate tumor suppressor genes, including P53. Dan Medina at Baylor and the Russos at Fox Chase have shown that even when the breast involutes after lactational changes, you can still show a genetic signature of high P53. So I think these early events are determinative, and it's really hard to tease that out. So we're seeing people 3 or 4 decades later.
Thank you so much.
No, you're good. All right, so we have 2 things for you. So the first is I called the governor, not really, but I called somebody in his office, and I told them how good you had been to one of their Kentucky's native daughters. And so they decided to bestow on you one of Kentucky's highest honors, which is a Kentucky Colonel. Churchill, Muhammad Ali, and Elvis. So you're in the good competition. Yeah, that's how you appreciate it. The second present is from Dr. Roman in the Department of Medicine, and this is a Louisville Slugger, which the Red Sox play with, and it's her name and the date of the lecture today.
Didn't work for them much. No, this is fantastic. I mean, I've never had anything like this. I wasn't the commander of public health service, so is this a promotion or? I never, since we were just public health service, we weren't too militaristic and we didn't really learn the ranks. Okay, thank you so much.
Thank you. Thank you.